Thank you so much. And we're going to plug in my computer. It'll just take a second. And while we're doing that, I just want to thank Dr. Banshee and the organizers for asking me to give this talk. It's really daunting to follow these wonderful lectures. And I sat there with my jaw dropped and just learned a tremendous amount. I have to tell Dr. Mohan that one of the most impactful meetings I ever went to and videos that I saw was by Andrew Hattersley at the Endocrine Society. And he showed a video of a child with neonatal diabetes who was diagnosed after a few years and who had motor problems. She couldn't walk and was then put on sulfonylurea after the diagnosis was made. And then the video showed how she was now walking. And it was just thrilling to see this. Aside from all the other benefits, making that diagnosis is really critical. So thank you for concentrating on that. And I totally agree. It's a mission that's well worth everybody's time. So I'm going to talk about something that I think all these three talks were perfect lead-ins to what I'm going to talk about. And that is automated insulin delivery. And why it should be the standard of care for type 1 diabetes. And it's really a remarkable set of discovery. Nothing happens overnight in medicine. This was an iterative process to where we now have 780G, which actually solves a huge number of problems for our people who have diabetes. What are we trying to solve for? Well, what's normal? What's normal is this tight link between insulin and glucose. And this, if we could achieve this, we would have an artificial pancreas. And I think we will, but we need better insulins because we have the algorithms that can almost achieve this. You'll also notice on this slide, and this is in people who had no diabetes, that the glucose stays within the 90 to, or even lower, 80 to 140 range. You never go, if you don't have diabetes, you almost never go above 140. You can have a hot fudge sundae with 2 cherries on top, and you will not go above 140 if you don't have diabetes. This is what we're trying to achieve. Here's the data that says that. This is a study, and it's one of 3 studies in which people without diabetes were looked at in terms of the glucose values, and you can see the distribution, and almost everybody, 96% of the time, 96% of the people are between 70 and 140. So that's really our goal. We want to treat diabetes so that people achieve glucose levels that are the same as those people without diabetes. Why do we do it? Well, you already heard about the DCCT. I'm not going to spend much time on this, but just remember in the DCCT, in which the intensive group was mostly on MDI, they had a very high rate of, it didn't come through, had a very high rate of hypoglycemia. So there was, in those with the A1C as low as 7, they had 60 events per 100 patient years. These were not just low glucose values. These were seizure, needing assistant, or coma. So there was a price to pay in that study, and yet it was very impactful, as you all know. And the EDIC trial, we've already heard about that. I'm not going to talk about metabolic memory or the legacy effect. What happened in the EDIC trial was everybody in each group regressed to the mean in terms of their A1C. So they were 9 in the control group, 7 in the intervention group, and 10 years later, they were all 8. And yet they got the separation of macrovascular complications that began about 10 years after the trial ended. And that's because the average age of people in that trial was 29 years. And they were not likely to have cardiovascular events in the next 10 years after this trial started. Here's the unappreciated organ that we haven't talked about. I was really delighted yesterday in the Pediatric Diabetes Symposium. Dr. Barkai talked about the brain in children with diabetes type 1 diabetes in particular. And there have now been several studies that have shown that hyperglycemia affects the brain in a number of ways. This is from the DirectNet group in the United States, showing that there was impaired spatial memory with hyperglycemia. This is a study from Tadej Badalino in Slovenia, one of the guiding lights of diabetes technology. He put people with type 1 diabetes in a functional MRI, and what he found was, and you see in the upper right-hand corner, that was a working spatial memory was decreased when they clamped them at hyperglycemic levels compared to euglycemic levels. And then in this study, I think a very impactful study, it was a randomized trial to see whether if you had a closed-loop system, automated insulin delivery, and did this and tested them randomized against people who were not on this, if you could actually affect a number of neural functions, including IQ. So here's what they accomplished, closed loop, not great closed loop because the time in range, it was only in the 50s, improved cortical surface area, regional gray volumes, fractional anisotropy, which is a metric related to white matter, perceptual reasoning and index IQ scores, and functional brain activity. And I've circled in that red box on the bottom. It's probably too small to see in the back, but the IQ actually was improved in those who were on a automated insulin delivery system. So how are we doing? Well, in the United States and Europe, we have registries, and the first registry up at the top, the red and the blue, are the T1D exchange. And this is the two studies separated by about 6 years. And you see that this is A1C over the age continuum. We're doing a little bit better in the adult population. The goal is less than 7%, according to ADA and EASD. But we still have problems with our adolescents and young adults. The second set of studies is from the EU. This is the SWEET registry, showing very similar trends. Overall, the people who have type 1 diabetes in Europe are doing better than in the United States, but you can see this spike as it goes up to age 18. So it's the same problem with the adolescents and young adults who have behavioral patterns that are different than the adults. And I will show you how the automated insulin delivery systems can mitigate some of that behavioral change. So on the left is the result of two consensus conferences, international consensus conferences, that established time and range and what time and range represented. So time and range, it was decided on it should be 70 to 180. You remember I said that's not normal. 70 to 140 is normal. But nevertheless, they said 70 to 180 is achievable, and you should be in that range greater than 70% of the time. When I used to go around and talk to payers in the United States, the insurance folks, this was about 10 years ago, I would talk about time and range, and I couldn't get to first base. They said, what's time and range? We only know A1C. So after hearing this a dozen or more times, I said, I'm going to show them and the world what the relationship is. And so there were only 19 studies at the time that were randomized controlled trials that had contemporaneous A1C and time and range. And I took those end of study results, put them on this regression analysis, and there's a very tight correlation between the two. And we learned that an A1C of 7% is equivalent to approximately 65% time and range. Turns out that this was one of the top 3 papers that was that's been cited in diabetes technology and therapeutics the year it was published, because everybody was asking the same question. We're A1C focused. Everything we want to be is A1C centric in terms of outcomes. Now this is a paradigm shift. Now we can talk about time and range, and I'm going to show you some evidence to that effect. So for every 10% change in time and range, it's equivalent to about 0.8% A1C. So this study from Belgium, the Muehlmeister, just came out last year, and they looked at 808 adults with type 1 diabetes and looked at the risk of microvascular disease. And if you have a 10% higher time in range, there's a 17% lower risk of microvascular disease and other, all microvascular diseases, not just retinopathy and nephropathy. So let's go back to this. People without diabetes spend 96% of their time in between 70 and 140. We're now starting to, again, add a new metric. And this metric is called time in tight range. Some people call it, I think a better name is time in normal glycemia. This is normal glycemia according to a population study of, with CGM or with CGM and who don't have diabetes. So why are we talking about time in tight range or normal glycemia and not time in range? So here's patient C at the top. And if you look in the box here, patient C has 75% of his or her time in range between 70 and 180. Patient B has 100% of the time in 70 to 180, but only 63% of the time is between 70 and 140. And patient patient A has 100% of the time in what we would consider normal glycemia. And the sensor glucose average for each one of these is 100, 135, and 147. We want people to be patient A, because if we can get people to normal glycemia 100% of the time, we will essentially eliminate complications of diabetes. That's a pretty broad and powerful prediction, but I do believe it because we've learned from the DCCT and the mega trials that we're headed, there's a trend to this, and now we need to take it to the next level. But we can't do that with MDI. We can't do that with just CGM. So it's very important that we have technology that will drive us to get this time in normal glycemia or time in tight range. And what does it mean in terms of A1C? So we now use a substitute for A1C. We used to call it estimated A1C. We now call it GMI. Glucose management indicator. And it's essentially the same equation that converts mean glucose to A1C. This converts mean glucose into GMI. And so GMI is reported in every trial. It's reported on the CureLink report for 780, and other systems report this. So what if you have in tight range, you're there 45% of the time. It's equivalent to a GMI or estimated A1C of less than 7. 50%, your GMI is less than 6.8, and 55%, you're less than 6.5. And that's kind of a magic number because we use 6.5 as the diagnostic criteria for diabetes. I'm not saying that if you get below 6.5, you're cured. Of course you're not, but that's been an established cutoff, and we have the ability to get people down to that level with 55% of the time in this normal glycemic range. So now, if you take what I showed you before, and you put the time in tight range, which is now dark green, 70 to 140, and the goal here is going to probably be established at ATTD next month, where another consensus conference is going to say, what should be the goal for time in tight range? And we think it will be either 50 or 55%, because that's the percent. 55% gets you to a GMI of less than 6.5. Is this feasible? That's really the key. And the answer I will posit to you is yes. How do I know that? Well, this brilliant paper by Boris Kovachev at the University of Virginia was just published last month, and he did a virtual DCCT analysis. Now, what does that mean? In the DCCT, everybody did a 7-point profile for 1 week every 3 months. And with 1,441 patients or subjects in this trial, you can imagine there were over 50,000 data points. So they trained a computer on those data points to construct a CGM curve for every one of those people. And then they looked at that in terms of, well, what was the time and range for the two groups, the intensive group and the control group. And you can see the intensive group, which had an A1C of just above 7, had a time in range around just south of 70%. And the conventional group had a time in range that was less than 40%. And you see the BGs in those groups were 155 versus 231. So he was able to take the data from the DCCT trial, and now, knowing all this and validating it, how did the time and range relate to the complications that were diagnosed? So here's the curve that I think is really most impactful. You see the time and range on the x-axis is 70 to 180 in this case, and you see the curve of the retinopathy rate, and you can see how the higher the time and range follows that curve and flattens out when you get above 80%. So this is really impactful. And then they went and looked at the hazard ratios of developing complication. And here's a very complex table, but you see that the hazard ratio for A1C is 1.35. So 35% risk of developing retinopathy in this case if you use A1C as a predictor. If you use time and range, it's up to 72%. If you use time and tight range, it's almost double, so 96%. So by using this virtual CGM from the DCCT, you can predict the risk or the hazard ratio of developing retinopathy. The same is true with nephropathy. Now, this is all, of course, retrospective data going back to times when we didn't have CGM, people were on MDI. What about more recently? Viral Shah published this paper a couple of years ago, and I thought was also very impactful because he had, at the Barbara Davis Center in Denver, Colorado, he had the CGM data on a huge number of patients that went back 6 years. And then they looked at those who got retinopathy and paired them with those that did not have retinopathy, and he found the risk ratio for time in range was 5%. If there was a 5% decrease in time in range, there was an 18% increased risk of retinopathy. And if he looked at time in tight range, if 5% change in the time in tight range was equivalent to a 28% risk. So this is not a randomized trial, it's retrospective, but it looked at the actual complications essentially in real time. So where are we in our diabetes technology world? Things have moved really fast in the last 10 years. And what I want to point out to you on this slide is that if you have CGM alone with MDI, it does improve things compared to BG monitoring, but you only get to 51%. And the guideline says we want to get above 70%. If you add a CGM to a pump, this is a dumb pump, doesn't take any action, you get a little bit more of a benefit. If you use a sensor-augmented pump, you get another boost. And it was only with the advent of the first hybrid closed-loop system, 670G and 770G, that you got 72% time in range, and in that trial, there was 6.9 A1C. Now with 780, if you use the recommended settings, you can get to 79%. So we're getting up to that level where the time and tight range may actually be within that GMI, or getting that GMI to less than 6.5. Now, if you look at the difference between the time and range between CGM alone, standalone CGM, and 780G, it's almost a 30% improvement with automated insulin delivery. And if you go back to that nomogram that I showed and the relationship of A1C and time in range, that's about a 2.4% improvement in A1C. So 780G, many of you know it. Hopefully Some of you have prescribed it for your patients, but it's basically a very sophisticated algorithm that is shown here. There's auto-basal every 5 minutes, auto-corrections up to every 5 minutes, and these auto-corrections are given safely so that every 5 minutes there's a calculation that's done to see whether or not it's safe to give 1 unit without causing hypoglycemia in the next 2 hours. And if that's the case, it'll cut down the amount of autocorrection to 0.75 or 0.5 until it finds the right dose that reduces the hyperglycemia without causing hypoglycemia. A recent network meta-analysis, which was a new term to me, was just published by the Italian group from Bari, and they found that in this network meta-analysis, you can see a number of systems, and you can see that the 780G improves the time in range almost 22% compared to SIT, which is subcutaneous insulin therapy, and other systems also improve over the MDI and with CGM, but 780G actually gets the best outcomes. So, getting close to finishing here. So this is a very complicated set of data, but the question that I pose on this is how well does 780G do with time in range and time in tight range? So here's the time in ranges here, and one of the take-homes here on the left-hand side is the adults, and the right-hand side are children at the age of 15, and you can see that children can achieve a time in range that is almost the same as adults. First time I've ever seen this, where if you use the recommended settings, they're almost the same, and they're high 70s or low 80s. But let's look at the time in tight range. In both cases, you're getting high time in tight range, especially when you use the recommended settings. And what's really notable is that that time in tight range is not because there's a reduction between 140 and 180. That stays exactly the same. What actually gets reduced is hyperglycemia. And that really is the magic of these automated insulin delivery systems, is taking the hyperglycemic part of the distribution and bringing it down into the 70 to 140, which is the real normal range. So how many patients can actually reach this target? This is in adults older than 15 years. It's 81% of adults can reach this with the recommended settings, and that's if you set it at 50% time in tight range, and 57% if you set it at 55%. Same thing with children. Actually, children are even a little higher. So you can achieve this. The majority of people can achieve a time in tight range of 50% and even 55%. So here I showed this again. If you can get to 50 or 55%, your GMI is going to be well under 7 and maybe even under 6.5. So why is AID the standard of care? Because of all this data, because it's possible. And mind you, all that was possible without any hypoglycemia. I didn't point that out in some of those stacked bars, but the hypoglycemia rate is 2%. And in the pivotal trials, there was no severe hypoglycemia despite achieving those high time in range and time in tight range. So here's what the conclusion of the American Diabetes Association, that AID, this is the latest recommendation, which they strengthen, should be the preferred insulin delivery method for children and adults, and it's level A evidence. And when early initiation, including at diagnosis. And in the US and in Europe, the pediatricians have taken this to heart, and many are getting started within the first month of diagnosis. The UK went a step further, and this is really exciting. They looked at the evidence. They realized that not only is AID cost effective, it's probably going to be cost saving. So every one of the 300,000 plus people with type 1 diabetes in the UK are going to get an AID system free. And finally, a group of key opinion leaders around the world have written and will be published in the next month's Journal of Diabetes Technology and Therapy a call to action. And this call to action is just walked out. Dr. Banshee is the first author, and we have the senior author is Professor Schwartz, who's the president of IDF, and this has been endorsed by 54 key opinion leaders in every continent and a huge number of countries, and I've highlighted the ones that are from India, and many of them are sitting in this room. And in addition, the organizations that have endorsed it include Breakthrough T1, ATTD, Diabetes India, IDF, and ISPAD, and the T1D exchange. So this will be published, and it's meant to be a tool for people where access to the therapy that really can normalize the time in range and time in tight, specifically time in tight range over 50% of the time, can go to the health ministries, could go to the insurers and say, look, everyone deserves to have this. Let's find a way to give this to our patients, and they will be happy, they will live longer, they'll live healthier, and in the end, this is really a good news story. So the call to action is that people with type 1 diabetes must be given a choice to use AID. We can't just let them find out about it 10 years later because they did a Google search, and it should be at the time of diagnosis or as soon as possible after. The reasons for not giving a choice should be documented because we want to know why, and there are reasons why, including people don't want to wear a device and they can't afford the small amount of money that in the United States the insurance will pay, but there's a copay. And in India, most people can't afford this. But if the government looks at this and looks at the benefits, just as the National Health Service in the UK did, I think we can make a lot of progress. The choice is based on individual circumstances and preferences. And the fourth point is the national healthcare systems should prioritize the provision of unfettered access to AID systems. So sorry I've gone over, but thank you very much.